Welcome to today's 30-minute web-based session titled COVID-19 Infection Control Competency Expectations. Handouts will be available after today's session. Our speakers for today are Lisa Thompson and Sue LaGrange. Lisa Thompson is the Chief Strategy and Marketing Officer for Pathway Health. Lisa's expertise and experience spans over 25 years in the post-acute and long-term care settings. Throughout her career, Lisa Thompson has been committed to supporting post-acute care operators by providing leadership, direction, and targeted operational strategies to enhance performance outcomes. Lisa's practical, hands-on leadership style, industry knowledge, and expertise are unparalleled in the industry. Lisa utilizes her extensive knowledge and broad base of experience to provide customers with expert professional consultative services. Sue LaGrange is the Director of Education for Pathway Health. As Director of Education, her primary responsibilities include planning and implementation of critical industry-leading educational programs, leading the learner toward regulatory compliance, implementation of best practices, as well as cutting-edge changes in the industry. Sue has 25 years of long-term care experience, which included Director of Nursing Services and consultant. She is a past president of the Wisconsin Director of Nursing Council.
We're going to start out today talking about objectives. We have two objectives for this 30-minute section. And the first one is we're going to identify 3 key employee competency topics during the COVID-19 pandemic. Now, certainly there's more than 3, but today we're going to cover 3. And we're also going to be covering some key strategies for education, competency, as well as evidence of understanding.
Thank you, Sue. And as we all know, competencies are crucial in all areas of post-acute care today. The requirements of participation or conditions of participation, as well as our state operations manuals, include multiple references and interrelated tags specifically to staff competency, including nursing staff competencies, as well as other mandatory competencies. There is also specific language that discusses the need for sufficient staff as well. So competency and skill needs of your staff are to be based upon your organization's resident population, that assessment that you do, the assessment of the current staff knowledge, skills, and ability, also known as KSAs, and competency-based training plans, which really provides that continuing education and training of staff members in order to meet the needs of your residents and the people that you serve. Now more than ever, infection prevention and control competency is essential for quality, safety, and compliance during the COVID-19 pandemic. Determining your staff competency needs follows really general guiding principles. And these principles can include, it's based upon that current situation of your organization, as well as the status of COVID-19 in your setting, including the new requirements and guidance. It also includes current policies and procedures for resident care and quality outcomes, specifically related today in our conversations to the novel coronavirus. And also utilizing your COVID-19 and infection control policies and procedures as a foundation for this competency development. In addition, as we talked about a little bit before here, that we should follow a KSA approach, those knowledge, skills, abilities needed for individual performance and improvement needs as based upon the current guidance and requirements. And incorporate those competencies into your overall training plan, specifically to your COVID training plan based upon today's needs. And align those competencies with staff job descriptions or roles and responsibilities, whether they are permanent or temporary staff working in your organization. And finally, we also know that we need to incorporate the competency review and monitoring processes into your documentation. And we know documentation is critical, not only on a day-to-day basis, but especially as we're in this ever-evolving COVID-19 situation. So incorporating your competency review into your COVID-19 preparedness, as well as incorporating into your overall QAPI performance improvement plan.
There are so many competencies that are necessary when it comes to general infection prevention and control program. Once again, we certainly cannot cover all of them today in 30 minutes. However, we are going to provide you with 3 competency areas that will be essential for quality during this time. Hand hygiene is going to be the first one because that still remains the #1 most important factor in prevention of the spread of infection. The second is going to be personal protective equipment, or PPE. We're going to talk about when to use, how to use, and really it's going to be important to have that staff competency in donning and doffing or applying and removing. And next, we're going to be addressing the importance of competency when it comes to change in resident condition. That identification of a change, the ability to evaluate that change, the action taken, notifications, and follow-up will be so important. Therefore, competency in those areas is going to be very important. A good system for education and nursing skills will be included in that section. And then we're going to end with a discussion on new employee training to include some of the new CMS information that is covered under the emergency declaration blanket waivers for healthcare providers. That is the training and certification of nurse aides. I do want to note the importance also of cleaning and disinfection. Even though we aren't going to talk about that today, that is still one of the key areas that will be important for your systems when it comes to competency, making sure that the staff are using an EPA list and disinfectant with environmental and equipment. And also, it will be important to include that topic in your facility competency program.
So there are many stages and steps in the development of a training and competency program. And today we're going to talk specifically about, as Sue indicated, 3 specific competencies as it relates to COVID-19 preparedness and response. And we know competency really is a measurable pattern of knowledge, skills, and abilities, those behaviors and other characteristics that our staff member needs to perform based upon their work roles and their functions. And that is not dependent solely upon their own qualifications or licensure. So when we're looking at knowledge, skills, and abilities, KSAs, we know that knowledge is really focuses on the understanding of that concept, the subjects or topics, and specifically today, talking about COVID-19 and infection prevention and control. And it also is knowledge is looking at that staff member should know at the time of their employment, annually, and determined as necessary. And the skills, when we talk about KSAs, is really the skills or those capabilities or proficiencies that are developed through training or the hands-on experience. Skills should be measurable and observable. And the abilities of the KSA quotient are really those traits or talents that a person brings to their role or to your organization or to their job position. So when we're looking at demonstrating a competency may not be just demonstrated simply by documenting that a staff attended a training, listened to a lecture, or watched a video. A staff's ability to use and integrate the knowledge and skills that were the subject of the training, lecture, or video must be assessed and evaluated by an individual already determined to be competent in those skills. So examples for evaluating competencies, again, as you can see here on the slide, is we're talking about that training and education. So when we're looking at that and evaluating competencies, we may look at ways of evaluating competencies, such as lecture with return demonstration for those physical activities. Or it could be simply a pre-test or post-test and documentation of the concerns or areas of additional education. Or we might be looking at demonstrated ability to use the tools, devices, equipment that were part of the training and used to care for our residents. Or reviewing adverse events that occurred, such as an indication of gaps in competency, or demonstrated ability to perform the activities that is within their scope of practice based upon an individual's license or certification. So therefore, as you can see on the slide here, during these unprecedented times, we need to find an efficient yet appropriate process to develop for competency in infection prevention and control. So we will break it down into 3 steps: training and education, secondarily looking at the verification of that competency, and then also an auditing process.
So if we take a look at the education with hand hygiene, We need to educate our staff on performing hand hygiene, even if gloves are used, before and after contact with the resident, before performing any aseptic task. Whenever they have contact with blood, body fluids, or visibly contaminated surfaces, or even after contact with objects in the resident's room, after removing PPE, the gloves, gown, face mask, even after touching the outside of that face mask, or even their goggles, after using the restroom, before meals. A few key points in addition to just the general hand hygiene. There are some other areas that show up in multiple areas of the long-term care regulations, such as F812, food safety requirements. The regulations indicate that antimicrobial gel cannot be used in place of proper hand washing techniques in a food service setting. So that's an area that will need to be included in the education. Also, alcohol-based hand rub should be used instead of soap and water in all clinical situations except when hands are visibly soiled with blood or body fluids, or after caring for a resident that has known or suspected C. diff or norovirus infections during an outbreak, or if those infection rates of C. diff are high. And in those cases, of course, we know soap and water should be used. So those are the types of things that we want to include in there. It's also important to educate staff on teaching the residents how to perform hand hygiene after toileting and before and after meals or snacks. We know that hand hygiene is a significant area where facilities run into difficulties during the survey process. Therefore, ongoing education in hand hygiene is going to be crucial. F880 outlines hand hygiene, as you can see, which again, it talks about the consistent standards of practice, and we just talked about that on the last slide. So again, this is going to be important because it is consistent with not only the regulations under the State Operations Manual for F880, it's also consistent with the CDC recommendations on hand hygiene. When performing hand hygiene, we do want to educate our staff in our procedure. So we want to pull out our policies and procedure, go specifically through and demonstrating how to wet their hands first, how to apply the recommended amount of soap, rubbing their hands together vigorously for at least 20 seconds. Now, certainly prior to the COVID-19 pandemic, some states had 15 seconds, some states had 20 seconds. Now it should be consistent throughout everywhere, 20 seconds at least, when they are vigorously rubbing their hands together, making sure to cover all of those surfaces of their hands and fingers, and then rinsing well, drying thoroughly with the paper towel and turning off the faucet. So that's going to be a key part in demonstration.
And as Sue talked about, as we educate our staff, we know that we have to look at some type of way to monitor that competency of our staff and based upon the education that we provided. And we know that hand hygiene, of course, is one of those skills in which it is important to observe a return demonstration for both alcohol-based hand rub as well as for soap and water. So be sure when you conduct your audits and you're verifying competency that you look at the amount of product used following manufacturer's recommendation for alcohol-based hand rub. It should be enough product, again, to cover the hands. And if soap is used, enough product to generate adequate lathering for scrubbing. We also need to observe that the vigorous scrubbing with soap and water or rubbing of hands until the product dries if alcohol-based hand rub is used. Then also timing, as Sue indicated, that 20 seconds, timing is very important. And for soap and water, that they rinse thoroughly, that we use a clean towel for drying, and then we turn off the faucet with the paper towel. Again, with that return demonstration that we review those key components for appropriate hand hygiene. So now that your staff have all been trained on hand hygiene and a competency has been verified, how are you monitoring that your staff are consistently compliant with your policy and procedure? A good audit tool is essential for process surveillance. And on the screen, you can see an example of a process surveillance tool. The infection preventionist can assign anyone in your facility to complete these audits. In fact, it's a good idea to have a variety of different eyes looking at staff. For example, housekeeping supervisor, nurse manager, administrator, and others. The more people watching will help you with compliance because employees will get in the habit of performing hand hygiene in the right way. Audits can also be used to identify who needs remedial on-the-spot education as well. So remember to document. Keep those audits as proof of process surveillance efforts in your facility.
Next, we will discuss education, competency, and then verification of the use of personal protective equipment or PPE in the facility. Never before have we heard the letters PPE more than we have today, whether it be in our facility, from state or federal web-based sessions, or even on the news as well. With COVID-19, PPE is so essential. However, if employees are not following the proper sequencing when it comes to donning, doffing, and the use of PPE, they will not be able to protect themselves or others if they're using them in a way that the product is not intended. The CDC identifies that before caring for patients with confirmed or suspected COVID-19, healthcare personnel must receive that comprehensive training on when and what PPE is necessary, how to put on or don the PPE, and how to doff or take off the PPE. They also expect education includes limitations of personal protective equipment, proper care and maintenance, as well as disposal of PPE. We also need to make sure that we're demonstrating competency in performing appropriate infection control practices and procedures. The CDC also indicates that personal protective equipment must be donned correctly before they even enter that patient area, such as an isolation room if you have someone that is on transmission-based precautions, or on a unit if you're cohorting residents. PPE also must remain in place and worn correctly for the duration of work in potentially contaminated areas, and should not be adjusted during patient care, because then we know they're contaminating their gloves and hands. PPE must be removed slowly and deliberately in a sequence that will prevent the employee from self-contamination. A step-by-step process should be developed and used during training as well as patient care.
So CDC provides this poster for identifying the proper use of donning or putting on, or doffing or taking off of PPE, as you can see on the screen. I would highly recommend that you download, copy, and even laminate it if you can, and place it in each isolation care area. The CDC indicates that training and practice of your facility's procedure is critical. So to put on PPE or donning, number one, gather the proper PPE, perform hand hygiene, put on an isolation gown first and then tie all ties. Next, put on N95 or face mask, put on a face shield or goggles, perform hand hygiene, and put on gloves. To take it off, again, sequencing is so important. Remove the gloves by glove in the gloving technique or other techniques as to not contaminate the hands. Remove the gown in a gentle manner away from the body. The rolling method is acceptable, and dispose in appropriate receptacle. Now, exit the room, perform hand hygiene, remove the face shield or goggles using care not to touch the front of the face shield or the goggles. Then remove and discard the N95 or face mask, taking care not to touch the front, and then perform hand hygiene. Facilities implementing reuse or extended use of PPE will need to adjust their donning and doffing procedures to accommodate those practices, and make sure that you're documenting that you've made adjustments and the rationale for those adjustments based upon the optimization of PPE.
Once your education is provided and demonstrated, after practice, the employee then needs to master both donning and doffing the PPE. Now keep in mind, when you're completing your education, if you are running low or if you are having problems with adequate supplies of PPE, be sure to follow the CDC personal protective equipment optimization guidelines and make sure you're telling the staff, educating and documenting what they're supposed to do in that case. So again, once we've educated and worked with our staff on return demonstrations so that we are sure that they understand how to don and doff their PPE. Auditing the use of PPE is also going to be part of process surveillance in order to determine if staff are following your policies and procedures for both quality and compliance. Auditing not only the correct sequence is important, but also observing that staff are not recontaminating themselves when they remove the PPE. The more often you are auditing, the better you are at being able to identify any additional needs for education and oversight for quality improvement.
During the COVID-19 pandemic, observing or monitoring all residents' employees for change in condition is essential for prompt action. We know that CMS has identified the need to monitor and document residents for fever and signs and symptoms of COVID-19. For employees, we are taking their temperatures before working on a unit and asking them about signs and symptoms, and if they develop them during shift, that they need to immediately leave the facility. And for residents, a good system for early identification of change of condition is essential.
The type of competency with change of condition will be determined by the staff's position in the facility. For example, a CNA or a housekeeper or even an activity aide should be competent in identification of an early change in condition. The nurse should be competent in that change of condition, but also competent in the ability to evaluate or assess the resident, report to the clinician and resident representatives, and in some cases, the director of nursing, infection preventionist, in order for mandatory reporting with communicable diseases. And then to make sure that they understand the documentation and follow-up process as well.
So as we know, we're looking at outlining the staff competencies in the requirements of participation. And we know that when we're looking at competencies as it relates to change of condition, that even in the midst of a COVID pandemic, change of condition competencies have not changed. That a facility must adopt certain tools to aid staff with those competencies. And those tools, as you can see here, we have AHRQ has tools, as well as the interventions to reduce acute care transfers. Interact, it's a program with several resources aimed at improving staff competencies in this area. So staff can inform surveyors of the tools that they use to help show evidence of those required competencies and their role and responsibility in identifying changes of condition of the residents. However, merely stating or referencing the tools is not enough on its own to verify compliance. So staff must demonstrate that they possess the competency to use the tools, whatever system that you're using, in a manner that accomplishes that purpose of aiding to effectively identify and address resident condition changes.
Competency in change of condition, especially during this COVID-19 pandemic, is essential, and that ranges from basics of vital signs to head-to-toe physical assessments. That assessment process competency will also need to encompass understanding of the resident's baseline, any deviations, any behaviors, and all body systems, so cardiovascular, respiratory, gastrointestinal, and such, even functional. And assessing that resident's skin will also be an area of competency that will be critical for the nurse to become proficient in, as we have residents staying in their areas and really not coming out and walking around as much as they have in the past. We also will need to ensure that our staff are competent in disease state management, pharmacology, diagnostics, and follow-up care. Once the nurse has completed the education that you've provided, any return demonstration or post tests and regular review of that documentation is really going to be important. One other point I would like to mention is use the resources that you have available to assist you with education. And that can be done in virtual settings as well right now with your medical director, if you're working with a nurse practitioner, even your pharmacy consultant, and sometimes even some of your hospital partners will have professionals and expertise that could be invaluable with your education. If you are using an online education platform, it's really important to ensure that your staff are attentive, when they're viewing that information as well.
And competency in notifications is essential for the licensed nurse. Now, for granted, some aspects of timing for notification is based upon critical thinking and common sense. However, other aspects, there are clear-cut directions on notifications with physicians, the resident representative, the resident, and certainly public health, as it is now with COVID-19, as well as the medical director, and reporting of COVID-19 cases within your organization and with other individuals as your policy deems appropriate under the situation. Verification of the competency can take many formats, from post-tests, as Sue talked about, to return demonstrations, to sign-in sheets, etc. So here's an example of a post-test required for knowledge check following a CNA educational session on identification and reporting of a change of condition. Another verification of competency format is competency checklist that identifies the education, if the employee needs additional training, your method of evaluation, for example, skills demonstration, performance observation, a written test, or a verbal test. Lastly, it's important for the instructor to document the verification of competency in each area. Keeping this information in the employee's personnel file will be essential as proof that you have done your due diligence in a solid process for education and competency.
Next, we're going to discuss the importance of a solid education plan for COVID-19 and how it fits into the infection prevention and control program. There is so much information out there today in regards to COVID-19. It's almost information overload. Once again, as we have indicated in previous webinars, it's really important that you're using reliable sources for your education for your employees, residents, and visitors for those end-of-life and compassionate care. CDC, Centers for Disease Control and Prevention, CMS, World Health Organization are great resources. Many of you also work with hospital systems that provide educational resources to use as well. It will be really important that you determine that education plan, have objectives for each program, determine who will deliver the education, how you're going to keep records, and who has and who has not been trained in order for you to make sure that you catch everyone, and then you want to document your method of training verification. So on this slide, you can see an example of the education for all staff. And of course, some of these topics can be tailored to the position. So again, these are just general policies, procedures, hand hygiene. We've talked about these, but these are some really good topics for you to include in your resident education or your employee education. When it comes to COVID-19 education, it should really include a description of COVID-19 and background to include symptoms. So for example, the fever, cough, shortness of breath, our breathing difficulty, chills, repeated shaking with chills, muscle aches and pains, headaches, sore throat, new loss of taste or smell. And we have had some of these that, and even we've heard red eyes that have come up over time. It affects older people and people with underlying chronic conditions harder than it does others, although there have been people that have not had underlying conditions that have also been extremely affected by COVID-19. Cleaning and disinfection, including those high touch areas. And so it's going to be important to work with our staff on that education. And even looking at things such as employees' phones, keyboards, pens that the staff are using. It's important that we look at social distancing. Even if a resident has behaviors and they're walking and we're trying to keep them social distancing, we're going to have to talk about that. Employee symptoms, personal protective equipment we talked about, and hand hygiene. Also, not touching their face, eyes, or mouth. And then the importance for both staff and residents on respiratory hygiene and cough etiquette. And there's much more. And those are just some of the areas that we really want to make sure we're including in that education.
And looking at COVID-19 education is that, You know, we also know that there were the emergency declaration blanket waivers for healthcare providers looking at the utilization of non-certified staff to be able to help our organizations. So again, we know that the blanket waivers have gone through, but CMS waived the federal requirements that require a skilled nursing facility or nursing facility that they may not employ anyone for longer than 4 months unless they met the training and certification requirements. CMS has the waiver of these requirements to assist in potential staffing needs during the COVID pandemic. However, we know that CMS is not waiving specific requirements about that we cannot use an individual working as a nurse aide that, again, for that no more than 4 months on a full-time basis unless that individual is considered competent to provide nursing and nursing related services. So part of that process is that they're not waiving the requirements to ensure that that nurse aides are able to demonstrate competencies and techniques necessary to provide care for residents and identified through resident assessments and described in the plan of care. So on this slide here is just an example of a non-certified caregiver, a basic nursing skills competency checklist. And again, when you're looking at that, you want to include in there such areas such as observational skills, taking a recording of vital temps, understanding the basics of normal and abnormal, and what to do if there's any deviations, documentation, you know, looking at eating and feeding assistance, care of resident care equipment, linen handling or bed making, dignity, abuse, pericare, bathing, grooming, again, the list that we have there. So these competencies will be in addition to the rest of your facility general education and training, which includes your abuse, resident rights, OSHA, emergency preparedness, and again, infection prevention and control, and much more. So as you can see, competency is crucial, especially during the COVID-19 pandemic. Competency is always essential, but never more important than today during this pandemic. We are all doing more with much less. It is the time that we are truly in need of all of our employees to be able to practice their position with competency and quality. We heard about 3 key areas that are just so important today. Hand hygiene, to prevent the spread for residents, staff, and others for protection. Personal protective equipment, in order for employees to protect themselves, a calm, competent approach each and every time they don and doff. Their correct sequence is essential, followed by, of course, hand hygiene. And change in condition, which is also so important for all staff, that we're monitoring our residents as well as themselves for any subtle changes in order for the nurses to be able to put into action the facility process for evaluation, isolation and transmission-based precautions, and appropriate care and services in order to take very good care of our residents and staff and to minimize the spread to others. Remember, keeping informed and accessing your resources in these challenging times is key for all of us. We encourage you to work with your partners and vendors and to access those resources like Sue talked about before, as well as education and solutions to assist you and your team as you respond to this ever-evolving COVID-19 pandemic. Together, we can do this, and we continue to provide the great care and services to our residents. You are all the true heroes of healthcare. We have also included additional handouts that you can download based upon your navigation panel. You can download, and those are additional audit tools, as Sue talked about how important it is when you're auditing and looking at the return demonstration and observation of effective education and competency testing and the application within your organization. We again want to thank you for taking this time today out of your very busy day to discuss the importance of staff competence during this COVID-19 pandemic.